Good afternoon, everyone. My name is Maya Luria with TMC for Seniors, and today we've got a very important topic. We're going to be talking about the link between hearing loss and dementia, and I've got Stephanie Bourn with me here. She is an audiologist over at Center for Neurosciences. Stephanie has provided us some great information in the past, and I know that this is an important topic. There's so much research on Alzheimer's and I think hearing loss with that link with hearing loss. So I'm really curious to hear what you have to say today about this topic, Stephanie. Thank you for being here.
Great. Well, thank you for having me. It's always great to come and talk at the TMC for Seniors group as well. We always get lots of great questions, but just feel like it's such a great group to be able to reach out with and partner with to help educate the community. So thanks for having me.
Yeah. So you may be watching us today on either our YouTube channel or one of our Facebook pages. Please, if you have a question, please leave it in the comments. And after we're done with the presentation, Stephanie will be happy to answer those for you. So I'm going to go ahead and put your presentation up, Stephanie. Thanks. And you're all set to go.
All right, great. Thank you. Okay, so today I'm going to talk a bit about hearing loss and dementia, and really to talk a bit about what the risks are, what the link is, and what some treatment options are actually for it as well. So this is me. I'm Stephanie Bourn, audiologist over at the Center for Neurosciences. I have actually also been working at TMC Audiology for the past several months. They have been a longstanding audiology practice that primarily focused on pediatrics, but more recently began opening up their practice to the general population for adults as well. So they've really been working to develop their adult program over at TMC Audiology too. And so they now have 3 full-time audiologists there to see patients of all ages. So from infants all the way to 100 plus as well too. So that's another really great option over there for you. Okay, but here at my practice, the primary practice I'm at, the Center for Neurosciences, we are the Ear and Hearing Clinic. And at the Ear and Hearing Clinic, we offer really the most experienced otologist and neurotologist in Southern Arizona. And an otologist and neurotologist is actually an ENT that only does the ear. And he also does lateral skull-based surgery. So we're a very specialized practice, or we partner with a very specialized surgeon here in this practice as well. And so we do a lot of medical audiology in this practice, in addition to general audiology as well. But in our Ear and Hearing Clinic, we have 2 full-time audiologists. We actually probably now have about 2.5 full-time or 2.5 audiologists. We have myself and my partner, Mary Rose Goldstein. And then we also have Alyssa Knickerbocker, who has been helping out in our clinic and will continue on doing 2 or 3 days a week. So we've been growing our staff as well. We also have audiology externs, which are students who are finishing their doctorates in audiology. We have 2 great externs this year partnering with us. We really pride ourselves on having this really personalized clinical care coordination, in that we really have our staff that really works to be conscientious of our patients' needs in regards to things like appointments. So when you might need an appointment with the surgeon, you might need an appointment with audiology, you might need a CT scan and an MRI, and we work really hard to coordinate those appointments and often try to make those all happen in a single day if we can, because it might be a big day, but we know that most of our patients appreciate being able to make one visit and get everything done, and that way the communication flows a little bit easier as well. In regards to testing and diagnostics, we really have a comprehensive hearing and balance program here, so we can kind of do the full range of diagnostic testing. We really have a state-of-the-art implantable hearing devices program. We're actually one of the larger cochlear implant centers in the state for sure. And we also have a complete infrastructure for clinical research too. So we have some really great people that work here at the Center for Neurosciences that have a dedicated research department. So the center does often participates in research. Specifically for the Ear and Hearing Clinic, we really focus on hearing research, and really our niche is elderly population. So the 65 plus population really is our niche, because that's one of the things that makes Tucson very unique, is that we have a large demographic of patients that are over 65. And there's really just a paucity of data in our field on patients who are 65 plus, patients who are 85 plus as well. So we've really been contributing to the literature on that. And we have about 5 publications right now that have come straight out of this group in the last few years as well. But really kind of the ultimate thing is that we really provide an unmatched level of care in Southern Arizona for all the disorders of the ear and the lateral skull base. So if you have just kind of a general typical hearing loss, maybe that comes with age, or if you have something that's more complex, a medically complex hearing loss as well, we can handle it all. All right. And this is just a great, nice group picture kind of our extensive team as well. And again, our vision really is to provide this personalized, compassionate, and state-of-the-art care. And really our goal is that we want to generate outstanding clinical outcomes. We always consider ourselves a center for excellence, and we're always striving for the best outcomes for our patients. And more importantly, we want our patients to be really satisfied with the care they provided and the outcomes that they've received as well. All right, so hearing loss. Let's talk a little bit about hearing loss now, okay? So hearing loss is very prevalent, all right? Over 48 million Americans over the age of 12 have hearing loss in one or in both ears, right? So this is not an inconsequential type of disorder, right? And this prevalence increases with every decade. No surprise here, but I think when you actually look at the numbers and we say, gosh, 20% of adults, 45 to 64, have hearing loss. Okay, 20%. And then you just jump up to 65 to 75, 30%, right? So now looking at a third of adults. And then over 75, 50, in the neighborhood of 50% of adults have hearing loss. You actually will also read some statistics that will say, upwards of 2/3 of adults over 75 have hearing loss. So the older we get, the more likely that we're going to be developing hearing loss, all right? And of course, this prevalence of hearing loss, the incident of hearing loss, is expected to increase simply because the population is aging. We're living longer, so we have more people on the planet that are older. Therefore, there will be more people on the planet with hearing loss. Okay. Now, there are studies more recently that show the impact of untreated hearing loss. Okay, so untreated hearing loss really just means you have hearing loss and you're not doing anything about it. You're not doing hearing aids or anything else, but you're just living with it. All right, it doesn't matter how much it's impacting you. If you have hearing loss and it's not being treated, then there are some risks that are associated with that. So there have been some more recent studies that have actually shown that there's a correlation with untreated hearing loss and greater incident of stroke, a greater incident of depression, and a greater incident of cardiovascular disease as well. This is all compared to individuals without hearing loss. So this is looking at people who have hearing loss they're not doing anything about versus patients with normal hearing. And there's a greater incident of stroke, depression, and cardiovascular disease. Who knew, right? That the ears could be related in that way. All right. Untreated hearing loss costs hundreds of billions of dollars each year globally, all right? And it's associated with anxiety, depression, decreased social ability, isolation, and just an overall reduced quality of life. I often talk with my patients about how important hearing is. I mean, hearing supports our ability to communicate with other humans. And that's what really separates us from the other animals, is our ability to communicate. And I often hear patients, maybe patients in their 60s or early 70s, will say, oh, I won't care if I can't hear when I'm 80 or 90. And we go, yes, you will, because again, it's your ability to communicate. As you're hearing, as you lose hearing, and if it's not being treated, it becomes difficult to communicate with your family, with your friends. It becomes difficult to communicate going out in the world. You're going to the grocery store and you're struggling to hear, right? That can create depression because you're struggling. You start to feel bad about yourself because you may feel that you look like you're not as smart as you are because you're simply not hearing what someone's saying. All those things can kind of snowball, and what happens is you start to not go out and do the things that you used to do. If you used to get together with friends and play cards, maybe you stop doing that because it's so hard, because you're struggling to hear and you're often missing what's getting said and people are getting frustrated with you. So then you stop interacting with other people. You stop doing the things that you love. You go to a family gathering and you sit in the corner and you play solitaire on your iPad because it's just too difficult to communicate because it's noisy and hard as well. Those things snowball and contribute to this isolation, to this depression, to anxiety, and the overall reduced quality of life. Now I want to take a moment to kind of talk briefly just about how hearing works, okay? So there really are 4 parts to hearing now, right? There's the outer ear, which is actually your, what's called the pinna, but it's the actual ear itself, okay? You have the middle ear. The middle ear is the ear canal, and then those little tiny, or I should say the middle ear is the eardrum and those 3 little tiny bones that live in there, okay? And then you have the inner ear. The inner ear is with something that's called the cochlea, which actually houses kind of the organ of hearing inside it as well, okay? And then number 4, most importantly, is the brain. So another thing I often like to say is that it's a myth we hear with our ears, we really hear with our brain, okay? So the ear, right? The ear itself, the ear canal, the eardrum, those little bones, and then the cochlea, those are just the mechanics. That's the part of the ear that captures sound and sends it in. But then it has to get to the nerve, and the nerve sends it up to the brain, and the brain makes sense of it, okay? So that's the really, really critical part is, gosh, can the organs of hearing gather and send the sound in at the appropriate volume? And then what does your brain do with it? So those are the kind of the 2 main parts of it. All right. Now, just briefly, and I don't like to get too deep into this as well, but there are a few different types of hearing loss. There's something that's called a conductive hearing loss. A conductive hearing loss is when that problem is because of an issue in the outer or middle ear, okay? So conductive hearing loss might be when you have an ear infection. So, or we all know what it's like to go up in the mountains or fly in an airplane and you're like, oh, your ears kind of get plugged up and you don't hear quite as well. Well, it's the same thing when you develop an ear infection and you get this buildup of fluid maybe that kind of is behind the eardrum, right? It's typically temporary because there's some problem with the making the eardrum vibrate and the bones vibrate in the way that they need to. So we call that a conductive hearing loss because the problem is in the middle ear, and the middle ear is what takes sound and conducts it through to the inner ear, okay? So conductive hearing losses are typically temporary. There are unique situations where people have a persistent conductive hearing loss, but for most people, conductive hearing loss is a temporary issue as well. Wax would be the other thing. You have to have a lot of wax for it to actually impact your hearing. So, you know, often people come and say, oh, I think I just have wax. It's not often that, can be that, but you have to have an awful lot of wax in your ear for it to cause that. But, you know, where your ear gets plugged up with wax, you don't hear very well, the wax gets removed and your hearing improves as well. All right. And then the next type of hearing loss is something called sensory neural, all right? And so sensory neural is hearing loss that is due to damage in the inner ear, into that little snail-shaped guide that's called the cochlea. All right. So often I have patients come in as well and they say, oh, I was told I have a nerve hearing loss or whatever. I always go, yeah, that's okay. There's nothing special or unique about a sensory neural hearing loss. It just means it's permanent, actually. So if you recall, I just said that a conductive hearing loss is usually temporary, meaning that once you deal with the issue, the fluid, the wax, things like that, the hearing improves and gets better. A sensory neural hearing loss is damage to the inner ear, and once it's damaged, there's no going back, okay? You cannot do something to make that better, so it just means it's a permanent and it's a real hearing loss. That is typically the hearing loss. That would be typically like a genetic hearing loss, or so an infant that's born with hearing loss. Or on the other end of the spectrum is the hearing loss that we develop as a part of aging. So the technical term for age-related hearing loss is called presbycusis, but it's just the natural course of aging for all of us is that we will tend to lose hearing gradually as we age. That's just a sensory neural hearing loss. It has to do with typically with these little hair cells that are in the cochlea, and that they just kind of get, you know, we lose some over time, and they get damaged and things like that. And so they just don't respond as well. And that just makes it a little bit more difficult for sound to get through. Okay. So you have conductive hearing loss, which is because of the middle ear. So a problem in the middle ear, and that's usually temporary. You have a sensory neural hearing loss, which is due to a problem in the inner ear and is permanent. And then you have something called a mixed hearing loss. And a mixed hearing loss is a little bit of both. That means that you have an actual real sensory neural hearing loss, a problem from the inner ear. And then maybe on top of it, you have some conductive issues. So let's say you have a real hearing loss, a permanent sensory neural hearing loss, and then you get an ear infection, right? So you get this temporary bonus hearing loss on top of it as well, okay? That's less common for people as well, okay? So conductive hearing loss and a sensorineural hearing loss create a mixed hearing loss. Okay, and then when we think about hearing, hearing is not black or white. It's not like you can hear or you can't hear. There are all kinds of shades of gray when it comes to hearing. So when we think of it as hearing sensitivity, and this is just kind of a representation of a graph that we use in audiology called the audiogram. And the audiogram really looks at two things. If you look at the screen and kind of moving left to right at the top, you'll see it says low pitch to high pitch, okay? So we measure frequency or pitch. And many of you all have had hearing tests where you hear them play beeps for you, and they're playing these really beeps, and then they play these really high squeaky beeps in there as well. So those are just testing. We are just testing a range of frequencies, and we're really focusing on a frequency range where speech is found. So human hearing actually goes way out far, much farther than we typically test, but we don't test in those really high frequencies because there's no meaningful or useful information for us. We test in this frequency range right here, which is about 250 to 8,000 hertz is the frequency range you focus on, because that's the frequency range where speech information is found. And as humans, that's what we care about, is being able to hear what other humans are saying. Now, the other metric that we look at when we're testing hearing is the volume. So you'll see that on the side here. So on the left-hand side, you'll see that at the top it says soft, and then it works its way down. It says loudness down to loud, okay? So it kind of seems a little bit backwards, but the top of the chart is soft sounds and the bottom of the chart is very loud sounds. So really, a hearing test is looking at pitch and volume. And what we're trying to map out there is we're trying to map out what is the softest sound a patient can hear at these different pitches, all right? And it allows us to plot your hearing sensitivity, and we can see, do you fall on the upper portion of the chart where you have normal hearing, or do you work your way down and you have some degree of hearing loss? Now, again, hearing loss is not black or white, and it's not all symmetric. So typically what happens when we're young is that we have a nice little straight line. When we plot that hearing, we have a nice little straight line right across that section that says normal hearing. Both ears are normal, it's great. And then as we get older with age, what starts to happen is over there on the right-hand side where it has the high pitches, we start to develop some hearing loss. So we start to fall down into the mild or the moderate range. But the low pitch sounds on the left-hand side, those tend to often stay in the normal range for at least some period of time. So patients tend to have some portion of hearing that's normal and some portion of hearing where they have a hearing loss. And that's one of the reasons that hearing loss is sort of this insidious thing. It just slowly creeps up on you because, again, it's not like a light switch. It's not like you can hear and then suddenly you can't hear. Some things you hear totally normal and some things you don't hear very well. So the most common complaint for adults who have age-related hearing loss is, it's not that I can't hear you, it's just that I can't always understand you, all right? So it's that difference between when someone says, hey, can you hand me my coat? And you're like, ooh, did you say coat or Coke, okay? That one word, that difficulty understanding that one word changed the whole meaning of the sentence as well. So I just often say that all speech is not created equal, okay? So, and again, it's not a black or white type of thing. All right. Okay, so those are the basics of hearing and hearing sensitivity. So untreated hearing loss. So we already said, untreated hearing loss, gosh, increases the incident comorbidity of things like stroke and depression and cardiovascular disease. But when we think of it specifically in the context of your brain and dementia, that untreated hearing loss, again, it leads to isolation, it can lead to depression, and it can lead to cognitive issues, including dementia as well, okay? So really, we like to create a sense of urgency here, which is that even very minor hearing loss really should be treated as a serious medical issue, because the earlier the intervention, the more likely that the treatment is going to be successful. If it's an infant, we always say, gosh, hearing loss is a neurologic emergency. You need to intervene immediately so that the baby's brain can react and adapt to a treatment intervention. All right, so the research has shown in regards to dementia and hearing loss that untreated hearing loss increases your risk of developing dementia or cognitive difficulties. Even a mild hearing loss doubles your risk of developing dementia, doubles it. A moderate hearing loss triples your risk of developing dementia. And a severe hearing loss, you've increased your risk by 5 times of developing dementia as well, okay? A mild hearing loss is like putting your fingers in your ears, all right? It's not that much hearing loss. It's a little bit, makes it a little bit harder to hear, but it's not a dramatic impact on your life. But it does affect you, and clearly it increases your risk for dementia as well. So I think important to note here is that just because you have untreated hearing loss is not a guarantee that you will become demented. It's not a guarantee. There will be plenty of people who have hearing loss who do not treat it, who never develop dementia or have cognitive difficulties. But this is about a risk factor. And so what we do know is the research has been clear that it increases your risk for developing cognitive decline or dementia as well. Not Alzheimer's. Alzheimer's is a different thing, right? Alzheimer is a different etiology as well. But dementia and cognitive difficulties, that's what we're discussing here, okay? So patients with untreated hearing loss are at an increased risk for developing dementia or cognitive difficulties for sure. So what the research has indicated is that there's kind of 3 main ways that untreated hearing loss increases this risk, all right? And so, untreated hearing loss is associated with anxiety, depression, which this often contributes to social isolation. And social isolation is a known risk factor for dementia, all right? It's very important. And again, we're human beings. We are meant to commune and be with other human beings. And so a lack of that stimulation and that input increases that risk for dementia, okay? Another one of the ways that increases the risk is that untreated hearing loss kind of shifts this cognitive load in the brain to compensate for the hearing loss. So really, and then I guess the other thing is it contributes to brain atrophy. So let's talk a little bit about those 2 things kind of in one thing. So the brain atrophy comes from our brain, of course, is wired. It has neural connections to all the different regions in our brain, which let's even think about them broadly, like just mainly our big 5 senses. Okay, so there are certain portions of the brain that are wired for sound and for hearing. All right. So our brain keeps these connections and it keeps the stimulation. When we start to develop hearing loss and that we're not treating it, then that means that there's portions of the brain that are no longer receiving stimulation to those hearing centers. And our brain is very efficient. It does not like to waste its energy, usually. So the brain starts to say, gosh, at some point it says, you know what? I used to have all these connections to this region of the brain, and now there's nothing happening. So I'm not going to waste my energy trying to connect to these sections. So it says, let me take those resources and I'm going to put them over here. Maybe that's smell, maybe that's vision, maybe that's taste, who knows? But it's going to say, I just don't need to waste my energy over here, and I'm going to reallocate these connections to a different region of the brain. Okay, so that creates some atrophy because that portion of the brain is going to kind of not die off, but it's going to get smaller and shrink because there's no stimulation going there. All right. Now, the cognitive load in the brain gets shifted because you're having more difficulty hearing. So you're trying to work with, you're interacting with somebody else and you're struggling to hear. So your brain has to work real hard to try and focus in on what someone is saying, trying to tune out competing noise as well. And it's just really straining. We've all been in that situation of having gone to a party or gone to a conference and it's so noisy and you're trying to talk to someone and you were like, oh my gosh, I'm just exhausted. COVID is a great example with masks. So many of us have experienced the difficulty of once we've had masks on, how much more difficult it is to actually understand one another, because we all use visual cues to help us understand what other people are saying. Even if we have normal hearing, we use visual cues. And suddenly you put masks on, you put a shield up, and it becomes a whole lot more difficult to be able to hear what someone's saying, and you have to really, really focus in on them as well. So you're just, again, you're shifting the cognitive load. You're asking your brain to put all of its resources into this one task at one point. So you have the social isolation, which is a known risk. So untreated hearing loss makes it more difficult to communicate with other people, can contribute to depression, contributes to anxiety. That can lead to social isolation. That's a known risk factor for dementia. You have neural connections that are no longer getting stimulated because of untreated hearing loss. So the brain reallocates those connections to different parts of the brain. And that makes that portion of the brain a little bit smaller or less active. And then when you are trying to listen, your brain has to work really, really hard on this one simple task. And so it's just making the brain work a whole lot harder than it needs to. Okay. Talking about COVID-19 pandemic has actually been, there's some interesting things that we've been able to evaluate in regards to hearing and hearing loss. So I think that, this is just an example of the impact that social isolation has on many of us too. So in a survey-based study on anxiety and depression that was related to the COVID-19 pandemic, about 67% of the participants reported a significantly worsened quality of life because of the anxiety and depression that they experienced. 23% reported moderate to severe anxiety, and 10% reported a moderate to severe depression. All right. And this is related to the social isolation, the fact that, gosh, we had these social isolation measures put into place, and the fact that most of us could not interact with people the way that we used to. We had to go many or very extended periods of time with hardly any interaction with one another. We couldn't hug people. We couldn't shake hands, as well. And that really created a lot of anxiety and depression because of that social isolation, right? And, as part of this, survey, our group actually we recently published some research on the effects of social isolation measures and cochlear implant outcomes for patients. We compared cochlear implant patients who were implanted and activated right at the beginning of the pandemic, compared them to patients who had been, implanted and activated, not in a pandemic condition. And what we found is the patients that were received an implant and activated at the beginning of the pandemic, their scores, their progress was less. And we believe that it's likely due to social isolation measures because they had less interaction with other people, and so their progress was less because they had less interaction, and then probably because there was some depression and anxiety, which then contributes to the lack of progress as well. But the thought here too is that elderly patients, so retired and older, may be particularly affected actually by loneliness, for example, because the elderly are often less able to mitigate the effects of isolation via technology. Now, certainly everybody here is on using, things like Zoom and Skype, to participate in things as well. But when we zoom out and look at that population on a whole, they have more challenges being able to overcome isolation with technology. And you add in having to use, so a young person may be able to say, okay, I'll just use FaceTime or Zoom or whatever to talk with my family. That's not a problem. If you're an older person who's maybe not as comfortable with technology, that may be a bigger struggle just to use the technology to connect with family and friends via video technology. But you add in hearing loss, which now makes it more difficult to hear through an iPad, through a computer as well. And again, the likelihood can start to be that older patients are maybe not participating in using technology as much as a younger cohort would be as well. And again, there's been research that has definitely shown us that older adults who engage in social groups and frequently visit relatives have lower morbidity rates than those who are isolated, right? So social isolation is kind of the common theme here, right? Is this common theme, this impact of social isolation on dementia, impact of social isolation on on morbidity as well too. So social isolation. So that circles back. What that links to is the ability to communicate, right? If we can hear and we can then communicate well with other people, we will tend to interact with other people more, which means that we will not experience as much social isolation. And social isolation is a big risk factor for dementia as well. So trying to do everything we can to minimize social isolation. All right. Frank Lynn is actually an MD, PhD out of Johns Hopkins, and he's actually kind of the, he's really known as one of the primary researchers. He's done a lot of research on this link between cognition and untreated hearing loss. And he kind of has a great thing here where he just says, boy, you know what? The general perception is that hearing loss is just a relatively inconsequential part of aging, right? Like we just go, well, it just comes with the territory. I couldn't tell you the number of times patients come in and say to me, oh, I was told my hearing is fine for my age. And I'm always like, well, that age norms do not exist. There are no, like, your hearing should be this at this age and your hearing should be this at this age as well. That there are, that just doesn't exist as well. But again, lots of research has shown that, that hearing really plays a much more important role in the overall brain health than we may have thought previously. All right. This is just some kind of nerdy research here, right? That just shows a few longitudinal studies. So big studies looking at, 20-year studies that really looked at this impact too. Again, so this is, nobody's making this up. This is real research, long-term research that evaluated patients, compared, normal hearing patients versus patients with hearing loss. Patients with hearing loss, untreated hearing loss, patients who had hearing loss with hearing aids as well, and looking at some cognitive testing they can do. So there's something called the MIMSE, which is the mini mental state examination, which is a really common cognitive evaluation that's done as well. So really what the take-home message here is that patients with hearing loss, if you had hearing loss, had an increased rate of cognitive decline compared to patients who had normal hearing, right? So hearing loss increases your rate. So untreated hearing loss, I should clarify, untreated hearing loss increases the rate of cognitive decline compared to those with normal hearing, all right? And that patients who wore hearing aids scored better on these cognitive exams compared to those with untreated hearing loss as well. So if you have hearing loss, you need to treat it because otherwise you really have a significant increased risk of developing cognitive decline and dementia. All right. So when we think about it as again, this has always been about a modifiable risk factor, that untreated hearing loss is considered one of the top most modifiable risk factors for dementia as well. So if you just look here as well, so you think like things like exercising is considered like, okay, that's a modifiable risk factor for dementia. Getting your treatment for depression, right? Stopping smoking, right? Smoking cessation. Those are really important things that, if you can stop smoking, get treated for your depression, and make sure you exercise well, that reduces your risk for dementia. But if you'll note on that chart, the number one of those four things, the top thing actually is treating your hearing loss. So treating your hearing loss is considered one of the most modifiable risk factors for cognitive decline and dementia. All right. Again, this just reiterates that as we get older, more and more the incidence of hearing loss increases. So the longer you go without treating your hearing loss, the older you get, the more likely that you're going to be developing hearing loss. And again, even a little bit of hearing loss increases your risk significantly for things like dementia and cognitive decline. And so early intervention is always better. With adults, the reason that we still say the same, we still have the same mantra of like earlier rather than later, is because it's always better to intervene earlier because your brain is going to be a little bit more plastic and more likely to adjust and adapt. Because hearing aids are not a magic fix. You don't just put hearing aids on and go, great, I can hear fine. It's a very sophisticated neurologic process. I think evidenced by the fact that the impact that it can have actually on your overall brain health. But it's a very sophisticated neurologic process. It takes time to acclimate to hearing aids, to adjust to them, and to kind of work your way up to where you should be with hearing aids as well. So it takes time to get into doing that. And it also takes time, I think, as a patient to develop the habit of it as well. So you can do that you can do that early when you only have a little bit of hearing loss, and all the things about you are a little better. Your brain's a little bit better. Your body's a little bit better. Your fingers work a little bit better. Your eyes work a little bit better, right? All those things you need to do to learn that new task to getting hearing aids on and wearing them consistently is easier when you're younger than as you get older, because we can't predict what the future will hold. But I'll tell you, it's a whole lot easier to work with a patient who is 68 years old and starting to use hearing aids for the first time and helping them to learn how and teaching them how. That's way easier than someone who is 88 years old, who's had hearing loss for 20 years, and now their fingers don't work real well, their eyes, they don't see as well as they used to, and it's just a much bigger struggle. And so we run into a lot more issues the older that someone is. Doesn't mean you can't. We can always do it, but it's certainly easier. The earlier you can intervene, the better that is for everyone. And then again, just talking about this, the risks of associated with hearing loss and dementia is that 1 in 3 cases of dementia could be prevented by increasing your education, increasing your activity, increasing your social contact, right? Social isolation, and decreasing your hearing loss, decreasing hypertension, obesity, smoking, depression, and diabetes. Okay, all right. So 1 in 3 cases could be prevented by addressing these kinds of lifestyle factors. All right. Hearing loss is seen as a very modifiable risk factor, and its hearing aid use is definitely associated with higher cognitive scores as well. And this may be because it just addresses those risk factors. So it may improve cognitive function because you've decreased your social isolation. So you're able to hear other people better. You're able to communicate. It's never perfect with hearing aids, but definitely better, definitely easier. So you're able to still do the things that you used to do. You can still go to the movies. You can still play cards with your friends, things like that. So you can stay connected with the people and things that are important in your life as well. Just by increasing the audibility helps to reduce the cognitive load on your brain. Once your brain does not have to focus so hard to hear what someone is saying, like I said, it makes your brain not have to work as hard as it needs to. So just by making it easier to hear, you're like, oh, I can hear it, versus having to focus to tune out the competing noise to hear what someone says as well. And then use it or lose it, right? You got to keep your brain wired for sound. So by keeping hearing aids on, you're keeping those neural connections to the hearing portions of your brain. You're keeping them stimulated, so you're keeping those connections there, right? So again, just to use it or lose it, right? Keeping your brain wired for sound is a really, really important component. All right. Treatment options. So treatment options really are dictated by the type of hearing loss you have and the degree of hearing loss. So what kind of hearing loss do you have? How much hearing loss do you have? But the vast majority of patients, the appropriate treatment option for them is hearing aids, all right? But less than 1 in 4 people with hearing loss are actually wearing hearing aids, right? So this is a huge struggle in our field, is that only about a quarter of patients with hearing loss are actually using some type of an intervention, all right? This is just, I don't need to get into all the ins and outs of all the different things that are offered. The big thing is that you want to treat your hearing loss as well. So for instance, if you come to see us here at the Center of Neurosciences, we're going to give you a comprehensive audiologic evaluation, and we're going to be able to offer you the full range of treatment options. All right. So we're the only clinic actually in Southern Arizona to provide the entire full range of treatment options. So we can do things from hearing aids to what are called bone anchored implants, something called a middle ear implant, all the way to cochlear implants. And we're very, very fortunate in our clinic because we do offer the entire continuum of treatment options as well. So we really have the luxury of being able to work with our patients, identify what their hearing loss is, identify what's going on, and be able to talk about all the different options. We're not limited to only doing hearing aids or only doing implants. We do all of the things. And so it's really, we're just really fortunate to be able to do that. And we can give our patients the choice of these are your treatment options, and then patients get to select the best thing for them, and then we can support them on that journey, whatever that journey actually is for them as well. And really just saying furthermore is that the hearing problems really are a significant and potentially modifiable risk factor for dementia, and things like executive functioning, working memory, and visual attention may actually also be improved by this treatment as well. And again, like I told you, our niche here is our patients over 65. We see everyone. I see pediatrics. We see everybody here. But our real focus in this clinic is on patients 65 and older. And so we feel very passionate about this group, and we feel very passionate about increasing access to technology and treatment options for our patients over 65. And so really, as the global population continues to age, the gravity of unaddressed or poorly managed hearing loss really can no longer be dismissed. And so we're very adamant about being able to offer the best treatment options for our patients, so that you're not untreated or undertreated. I think that's another thing that can actually come up, is that a patient can be undertreated. Like, you might have hearing loss and they might be like, oh, I have hearing aids, but hearing aids might not be the best thing for them. Maybe they're actually a cochlear implant candidate. And in that sense, maybe a patient might be undertreated as well. So again, that's why I think I'm very fortunate at this clinic, because we offer all the treatment options and we can really work with our patients about what are the best options for them and help them make the best decision for themselves. Well, and just because I think this is a great slide that really helps to drive home the importance of or the link between dementia and untreated hearing loss. Again, remembering that even a very mild hearing loss doubles your risk of developing dementia. Moderate hearing loss, it gets tripled, and a severe hearing loss increases your risk by 5 times. And that treating your hearing loss really is seen as, what we found again is that treating the hearing loss, especially early, is going to or can help improve those scores overall. Once someone has developed some dementia, you can't not reverse it. But that's why, again, early intervention is always better, because you want to try and mitigate and offset that as well. At the center here, we work with, of course, with many neurologists and neurosurgeons, and many of them have now made it part of their sort of just general workup. They might see patients who the reason they're seeing the patient is memory loss, is that the patients are like, gosh, I just am not remembering things the way that I used to. I'm struggling more. And so they're getting a workup for memory loss. And so they're doing all kinds of things, MRI and CT scans and blood work and neuropsychological examination. And they're also adding audiology in there as well, because they have also learned that hearing loss is a really important component of that. And so they want patients, as part of their initial workup, get your hearing tested. Let's see where you're at. Gosh, if you need hearing aids, we should probably think about hearing aids, because we need to isolate. We need to not make it harder for you, unnecessarily difficult for you too. So sometimes just having some hearing aids and making it easier to hear makes it can help offset some of those risks, but at least it won't make it worse for a patient as well too. So anyway, that's probably my soapbox on it as well. All right, so thanks so much. I really appreciate the opportunity to talk about it, and I'm happy to answer any kind of questions that we may have.
Thanks so much, Stephanie. I did have a couple of questions that came in, and boy, those facts are hard to hear, right? With the 2 times, 3 times, and 5 times. So I've got a couple of questions that came in. One was, are there any steps that you can take to help prevent or delay more severe hearing loss? Really the primary thing. So again, it's the natural course of aging for all of us. So if we're just talking about typical age-related hearing loss, not, caused by specific trauma or illness or something, but the biggest thing you can really do is protect your hearing. So, which means that minimize noise exposure, and wear hearing protection when you're going to be around loud noises. If you're going to a concert, wearing some earplugs, right? So you can still hear things, but your ears are not getting blasted as well. We're seeing more and more young people, teenagers, with noise-induced hearing loss from wearing earbuds, all the time. And lots of us are doing that we're wearing earbuds and headphones. And so we're really kind of putting a lot of sound at a high level in our ears for extended periods of time. So that's probably actually one of the most important things you can do, is to protect your hearing from unnecessary noise exposure. But there's not really anything you can do specifically. It's like vision, right? You can't do, if you're going to develop, if you're going to need readers, there's not really anything you can do to offset that, make that yourself. Right. And have you seen a rise in the untreated hearing loss during the pandemic?
What's interesting? I don't have statistics on that, but I would say anecdotally, we've actually seen the reverse. And part of that is because that we actually found that we talked to more patients about hearing aids than we had, previously, because we think it's because patients had, one, the masks really identified to people how much difficulty they were having. So even somebody who had maybe a little bit of hearing loss, who did okay, you suddenly start putting a mask on and shields, and patients were like, oh my gosh, I'm really struggling. And so they realized they were having more difficulty. The other was that, especially in the first half of the pandemic, because patients were not traveling, they also had the funds, because hearing aids are not covered by Medicare. And so that's an out-of-pocket expense. And so patients had travel funds that they were no longer using. And so people said, well, gosh, you know what I'm going to do? I'm going to invest in my health. And they did things, people were getting procedures done and doing things like hearing aids, investing in hearing aids, because they had some excess funds to do so.
So I actually had a question about the cost of hearing aids. Are there any more affordable options or any plans that somebody might want to take a look at? I don't know,
Mm-hmm.
what are the options if you don't have the funding to purchase those hearing aids?
Yeah. So there are definitely options. So I think often patients come in with like, oh, I was told I have to spend $5,000 or $6,000 for a set of hearing aids. We don't do that a lot in our clinic. We don't do $5,000 and $6,000 hearing aids in our clinic as well. I think that it's real common for patients to be spending $2,500, $3,000, $3,500 for a pair of hearing aids and all the programming that you need. So it's still not an inconsequential number by any means. But I can tell you, so when it comes to Medicare does not cover hearing aids. It's just not a thing. They don't do it. Our public health partners are working on that. And part of it is actually being able to demonstrate this link between cognition and hearing and hearing loss, that it's really a public health crisis to not treat the hearing loss. But currently Medicare does not cover hearing aids. There is one plan, there's a United Healthcare plan. If you have United Healthcare, you very likely have access to something called United Healthcare Hearing. And that's like an arm of their insurance. And in there, most patients have access to some discounted pricing. It's about 20 or 25% less than if you had to pay directly to a clinic out of pocket. So it's still it's still significant, but you're saving money. Nobody would pass up a 20 or 25% discount on about anything. So United Healthcare Hearing, you probably have that. Some patients have a combination of Medicare, Medicaid, and that actually will provide them a benefit. There are things like, certainly you can go to Costco and you can get hearing aids there. That means, and that's probably a more affordable kind of region. I think the thing you have to be careful about is that when it comes to hearing aids, there's no magic in hearing aids, but the magic, if you want to say, in hearing aids is in the programming. It's not the device itself. All hearing aids are digital and they're programmable and they do really great, but it's in the programming. And that's where you really want the expertise of an audiologist, and either a very experienced, very, very experienced audiologist, a doctorate level audiologist, right, who's gone to school and done a lot of education on how to program hearing aids correctly. I think that's probably a really, really important thing. So the product itself, I think, is less important than that. For very much lower income, you start to do things like there's the hearing aid bank at the University of Arizona. So if you are very low income, you can go there and you can apply, and you can usually get like one hearing aid for maybe $100. And it's a refurbished hearing aid, but the University of Arizona manages that. And then the other is an organization in town called Grace Hearing. I don't know a lot of their details. I think that Grace Hearing, they have a similar thing. They have a low cost hearing aid, but you may have a low cost and you might have to do something like a community service component to it as well. So there are a few other options, in there as well.
Great. And I had another question come in about how long do you suggest that somebody wear a hearing aid each day? Is there a max, a minimum that you should really be doing?
That's a great question. That's a really good one. So we always say the goal is all waking hours. So you don't wear your hearing aids when you sleep, and you don't wear them around water. But otherwise, the goal is all waking hours. You got 2 ears on your head. It's on your head they're on there all the time. You should be maximizing your hearing all the time. In the beginning, though, I say when you're starting to use hearing aids, the best thing is consistency. So even if we start off with 3 or 4 hours a day, I'm real happy with 3 or 4 hours a day as long as it's every single day, because not wearing them at home because you're like, I don't struggle at home, it's quiet, but then going, oh, I'm going to go to Trader Joe's or I'm going to a restaurant. It's a recipe for disaster. You're never going to like them. They're going to sound echoey. They're going to sound loud. And you're going to be in this cycle where you're like, they don't help me. They're noisy. But you have to give your brain time to acclimate, and you acclimate with consistency. So I usually recommend a few hours a day, and then we just work it up over time. Over a month or so, we can usually increase patients to where they're wearing them. We like to see double digits. So 10 hours or more is what we really like to see.
Okay, great. Now, if somebody wanted to make an appointment with you, I do have the number running up on the screen right now. It's 520-795-7750. But I had a question asked, do you need a referral from your PCP?
It depends. So it just kind of depends. So patients can self-refer. So everyone's insurance is a little bit different. So if you call in and you want to get to go to audiology, they'll figure that out for you if you need it or not too. So it just kind of varies a little bit. It's not a guarantee that you have to have that referral. But yeah.
Do you know if Medicare requires that or?
I just don't know. I'm sorry.
I know, not the insurance side.
I know. I was like, I should find that out because I'm just too removed, right? That's a whole other department, that does that. So.
Okay. So please call if you are interested in an appointment. Then your team will let them know whether they need a referral. Again, the number is 520-795-7750. So I want to thank you so much for being here today. It is enlightening to hear about that link between dementia and cognitive decline, and particularly with the numbers, because they are quite staggering. So we should definitely be watching out for that and taking care of our ears as well as best we can. So thank you very much for being here, Stephanie, and we look forward to seeing everyone. We don't have any more talks this week. Our next talk will be coming up in October, so stay tuned. I don't think we've got another talk coming up until Monday, October 11th. But thank you all for being here, and thank you, Stephanie.